Good afternoon and welcome to our Oncology Lecture Series. I am Dr. Galler Hakim, Assistant Vice President of International Healthcare Partnerships and Insurance Development at Baptist Health International. It is my pleasure to welcome all of you to this informative presentation. I would like to extend warm greetings to our friends across Latin America and the Caribbean and everyone joining us today. During this interactive presentation, you have the ability to ask questions via the Q&A feature located in the bottom of your screen. I will be your moderator for today's lecture. This afternoon, I have the distinct pleasure of introducing Dr. Alessandro Villa. His presentation is titled Oral Medicine and Oral Oncology, an Update. Dr. Alessandro Villa is a Chief of Oral Medicine, Oral Oncology, and Dentistry at Baptist Health Miami Cancer Institute and a professor at Herbert Wertheim College of Medicine at Florida International University. He specializes in treating oral mucosal and salivary gland diseases, oral precancers, and oral complications from cancer treatments. Dr. Villa earned his DDS at the University of Milano in Italy and his PhD in preventive dentistry from the University of Sassari, also in Italy. He went on to complete a postdoctoral fellowship in cancer epidemiology and genetics from the National Cancer Institute at Rockville, Maryland, followed by a research fellowship in oral diagnoses from the University of Milano. He completed his oral medicine residency at Brigham and Women's Hospital, Harvard School of Dental Medicine. In addition, he holds a master's degree in public health from the A.T. Still University in Kirksville, Missouri. Prior to joining Miami Cancer Institute in 2022, Dr. Villa was an attending physician at the University of California, San Francisco Medical Center and an associate clinical professor of oral medicine and otorhinolaryngology at the University of California, San Francisco. He also directed the oral medicine residency program at the University of California, San Francisco and Harvard. While at the University of California, San Francisco, he earned the 2021 Short-Term Mentor Award and was the Diversity, Equity, and Inclusion Champion at the University of California 2021. A renowned researcher, he focused on oral dysplasia, oral complications from cancer therapy, and prevention of HPV-associated oropharyngeal cancers. Dr. Villa has been principal investigator in several clinical trials, including the use of immunotherapy to manage oral proliferation leukoplakias. His research has been published in the Journal of Cancer Education, Cancer, JCO Clinical Practice, and the Journal of the American Dental Association, among many others. Dr. Villa is a diplomat of the American Board of Oral Medicine and a fellow of the Royal College of Surgeons of Edinburgh. He's a member of the American Dental Association, American Academy of Oral Medicine, Multinational Association of Supportive Care and Cancer, International Society of Oral Oncology, and of course, the Florida Dental Association. Please let's give a warm welcome to Dr. Alessandro Villa. Dr. Villa, what a pleasure having you. Thank you so much for accepting our invitation. The floor is yours.
Thank you so much, Dr. Hakim, for the nice introduction, and welcome everyone to this afternoon lecture. Today, I'm going to discuss and talk about oral medicine and oral oncology and give you an update of this new brand service that we put together at Baptist Health Cancer Center. For those of you who are not familiar with oral medicine, this is a discipline that really bridges the gap between dentistry and medicine. Oral medicine specialists interact with a variety of different services within medicine, from oncology to dermatology and many others. And as oral medicine specialists, we deal with autoimmune conditions that can affect the mouth, salivary gland disorders, and all the complications from cancer treatment, including chemosensory and neurologic impairment of the oral and maxillofacial complex. And today, we're going to review some of the most common complications from cancer therapy, and I'll share with you some of the interesting findings related to the management of oral precancers. In general, when patients are diagnosed with a cancer, most of these patients require a dental visit. So we work closely with general dentists in the community during the screening and preparation process before starting cancer therapy. And as oral medicine specialist, I think one of the advantages is that we can build medical insurance, and we support patients during treatment and after treatment and manage both chronic and acute complications from cancer therapy. This is a relatively busy slide that was published from a recent paper on oral complications from cancer therapy. And this is just to show you that patients can be affected by treatment, and their mouth can also be affected by all the different treatments now available for the management of cancer, from surgery to radiation therapy to the head and neck, the cytotoxic chemo regimens, the conventional ones, patients undergoing bone marrow transplantation, and all the new targeted therapies and immunotherapy have been associated with side effects that affect the oral cavity. So having a supportive care service that focus on the mouth and helping these patients, it's becoming really integral part of the cancer team. This is to show you a brief summary of some of the most recent oral toxicities from cancer therapy, from mTOR inhibitor stomatitis in patients receiving mTOR inhibitors, either for GVHD prophylaxis or for the management of certain cancers, or in patients that underwent kidney transplant. Most of you are probably familiar with oral mucositis secondary from radiation therapy or chemotherapeutic agents, including some of the newest monoclonal antibodies. We were the first group to characterize oral dysesthesia, also referred as stomatitis, in some of the large clinical trials in patients receiving VEGFR inhibitors. And dysgeusia has been also reported after the administration of some of the newer targeted therapy agents, including bevacizumab. And dry mouth is another very common toxicity from cancer therapy, either from immunotherapy, and we'll see a few practical cases in the next few slides, radiation therapy to the head and neck in patients with a diagnosis of head and neck cancer, or secondary to some chemotherapeutic agents. So these are some of the examples. These are patients that I saw over the past few months. As you can see here, the clinical presentation of some of these oral toxicities varies depending on the type of agent considered. The first patient was a patient with a history of rhabdomyosarcoma who received chemotherapy, developed extensive oral ulcerations of the right and left tongue. These patients have trouble eating, swallowing, and speaking. It's a very morbid condition. And oral mucositis remains actually the #1 cause of hospitalizations in patients receiving radiation therapy, for example, to the head and neck, with a median cost per patient of up to $25,000. So not only this is a very morbid condition, but also from a public health standpoint, it's very costly. I mentioned earlier medication, mTOR inhibitor associated stomatitis. These patients develop aphthous-like ulcer. They tend to be round in color, round and yellow in color, associated with an erythematous halo, similar to a canker sore. And these tend to resolve once the agent is discontinued, and the management is typically with topical steroid therapy. We characterized also immune-related adverse events. These can manifest in the mouth in different ways, and we'll see this more into details in a few minutes. Dry mouth, patients may develop dry secretion. Dry mouth is also associated with secondary fungal infections like oral candidiasis and the development of rampant caries on their teeth. And patients with dry mouth may also present with anatomic changes of the dorsal tongue, with fissures and pain, all of which are usually secondary to certain medications or poor hydration, specifically in cancer patients. Immunotherapy-related adverse events have been described in the last 5 to 10 years. As you know, immune checkpoint inhibitors have really changed the way we treat patients with cancer, starting from melanoma, metastatic head and neck carcinoma, and also other hematologic malignancies. This is the work that we have done in collaboration with some colleagues at Harvard. We looked at about 4,600 patients that receive immunotherapy for different types of cancers, and we focused on oral manifestations from the use of immunotherapeutic agents, and about 7% were affected by some sort of toxicities that involve the oral cavity. 1/3 of these patients had mucosal disorders, 2/3 about dry mouth and xerostomia, and 20% reported taste changes. And what was interesting to notice is that these toxicities tend to develop during the first months of treatment, although a small percentage of patients may develop oral complications even later on after several infusions with immune checkpoint inhibitors. We also compare the days to onset between non-oral immuno-related adverse events and mouth-related immuno-adverse events. And interestingly, we noticed that patients tend to develop toxicities at different organs around the same time. So when a patient, what does it mean? It means that if a patient starts developing, for example, oral mucosal changes after receiving infusions with immune checkpoint inhibitors, these patients are most likely to develop other toxicities at different sites around the same time. I mentioned earlier dry mouth being a very common oral complications from cancer therapy. Salivary gland hypofunction, it's usually caused by 3 different conditions. One, salivary gland graft versus host disease in patients receiving allogeneic hematopoietic stem cell transplantations. Medications play a huge role in this toxicity, and patients undergoing radiation therapy for head and neck cancer can develop irreversible effects after receiving 25 grays of radiation to the salivary glands for the management of some of these cancers. So the impact of salivary gland hypofunction is really significant in all of the cancer patients that we see on a regular basis. Dry mouth, I mentioned earlier, can manifest with pain, discomfort, sensitivity, tingling in the mucosa, dry secretion, secondary candidiasis infections, and these patients also are at a higher risk of developing dental disease, in particular dental caries, and should be followed by the dentist on a regular basis to make sure that they are protected, and should be placed also on long-term high concentration fluoride therapy. Another complication that patients may develop, especially we are considering now head and neck cancer patients, is osteoradionecrosis. Osteoradionecrosis is caused by a reduction in the vascular supply and a reduced healing and regenerative capacity. Radiation really affects osteoclasts, osteocytes, and osteoblasts in these patients, and necrosis may be triggered by a traumatic event after receiving radiation therapy, for example, a dental extraction or a surgical procedure that involves the manipulation of the bone or the gingival tissue. And a diagnosis is made clinically when patients have a persistence of greater than 2 months of exposed bone, either in the maxilla or in the jawbone. And patients typically, this condition typically affects mostly the mandibular bone because it's less vascularized compared to the maxilla. And patients who received at least 60 grays of radiation to the jawbones have about a 5% increased risk of developing this complication. This is a patient with osteoradionecrosis. There are different stages, and over the years, there have been a plethora of different classifications. to stage these patients, and treatment varies depending on the severity of the condition and the severity of the stage. As you can see here, the patient had an area of exposed bone of the right mylohyoid ridge. We perform a non-surgical sequestrectomy of the bone with complete reepithelialization of the area. And radiographically, osteoradionecrosis manifests with radiopacity mixed with radiolucency, depending on the stage of the condition. A very interesting complications from cancer therapy is oral dysesthesia. Patients complain of a burning pain sensation in the oral cavity in the absence of any pathology upon intraoral examination. This is a relatively old study where some of my residents looked at VEGFR toxicities, and we included about 750 patients. These patients were on a TKI, and after 4 months of treatment, they started to develop dysesthesia. Dysesthesia is a relatively common complication for TKIs. It develops in about 1/3 of the patients with a median time after treatment of about 2 months. The treatment of oral dysesthesia is with topical agents, mostly to control the symptoms. Initially, for acute phases, patients may benefit from a mix of Benadryl, lidocaine, and Maalox, what we call magic mouthwash or viscous lidocaine. But long-term, there are other options that have been reported in the literature, like clonazepam compounded as a swish and spit, or more recently, we started using gabapentin as a swish and spit, and other over-the-counter palliative rinses, such as oral moisturizers like biotin, or baking soda rinses, or salt water rinses. Switching a little bit gears, and again, I'm just giving you a general overview of the type of the conditions that we can help you with your patients. Specifically for bone marrow transplant patients, these patients that are higher risk of developing chronic graft versus host disease. These are all different patients that develop GVHD in the mouth. GVHD manifests with white reticular changes or ulcerations along with erythema. Some of these patients may also develop salivary gland GVHD with secondary salivary gland hypofunction and severe dry mouth. The condition clinically resembles another immunomediated disease called oral lichen planus. And these cases typically respond well to ancillary therapy with topical steroid treatment or other topical immunosuppressives. These are patients with multiple myeloma that develop or extramedullary manifestation of the underlying hematologic malignancy with large plasmacytomas that cover the entire area of the teeth, and patients have trouble closing their mouth. So these patients require surgical debulking, but these lesions tend to recur very rapidly. And these are done usually in conjunction with the management with the hematologic malignancy team. And patients also on bisphosphonates or any other anti-resorptive therapy may develop a complication called medication-related osteonecrosis of the jaw. These complications was initially observed about 15-20 years ago in patients receiving Zometa for cancer metastases. But over the years, new reports came out, and there were also some cases in patients receiving bisphosphonate therapy for osteoporosis. The risk is dependent on the type of agent considered and on the also indication of use. So if a patient is taking an anti-resorptive therapy, either Zometa or denosumab for cancer reasons, the risk of having medication-related osteonecrosis of the jaw is less than 5%. In patients taking anti-resorptive therapy for osteoporosis, the risk, we know that it's now less than 1%. Nevertheless, these patients should maintain optimal oral hygiene, see the dentist regularly, and if they are on either of these agents, they should avoid any surgical procedures that involve the bone or the gums in these cases. What I'm showing you here is a 55-year-old male with a history of multiple myeloma who was on denosumab and presented with pain in his right and left jaw. As you can see here, he had two areas pretty large of exposed necrotic bone of the right and left mylohyoid ridge. The patient also developed a secondary infection in the anterior part of the mandible. This is what we call a stage 2 medication-related osteonecrosis of the jaw. Again, a complication that can occur in up to 5% of patients, depending on the agent considered, and it's also dose dependent. One of the one area of interest of mine, and also an area of research, as Dr. Hakim told you earlier during the introduction, is leukoplakia. Leukoplakia represents a potentially malignant disorder of the oral cavity. It's been described also in other sites like vaginal leukoplakia or laryngeal leukoplakia, but it affects about 1% of the population in the United States. Is more common in South Asian countries. The prevalence is about 4%. And these are precursors of oral cancers. I'm showing you here two patients with what we call localized leukoplakia. Leukoplakia is characterized by a white plaque with well-defined margins. The tongue, as you can see here, is the most commonly affected site. And these conditions have a malignant transformation rate that goes from about 7% up to 22%. So these patients over a 10-year period of time have relatively high risk of malignant transformation. There is another condition called proliferative leukoplakia, previously referred as to proliferative verrucous leukoplakia. This is the same patient with multiple plaques that affect different sites in the mouth. He had a large leukoplakia of the gingiva, of the right ventral tongue, floor of the mouth, and left tongue. These are patients with multi-sites leukoplakia, and typically these patients have a malignant transformation rate that is higher than the localized unifocal lesions, which goes up to 100%. So again, these are high-risk conditions where patients may develop cancer in a 5 or 10-year period. Because of the limited treatment options, some of these patients can be treated with surgical excision, but other patients are more challenging to treat. For example, when you consider the proliferative type, where these precancers are really at different sites and pretty large in the mouth of the patients. We hypothesize that the immune microenvironment and gene expression patterns would be distinct for proliferative leukoplakia compared to the localized type. And we looked at 58 patients, 29 with proliferative leukoplakia and 29 with localized leukoplakia. And only what we found was that only the clinical diagnosis of the proliferative type, the one that affects multiple areas that is associated with an increased risk of malignant transformation, was associated with a significantly decreased cancer-free survival. And when we look at the CD8 T cells and T regulatory cells, these were more abundant among proliferative leukoplakia samples, regardless of the degree of dysplasia. And the gene set analysis identified granzyme M as the most differentiated and expressed gene favoring the proliferative leukoplakia subgroup. So we also looked at the proliferative leukoplakia malignant transformation within a 5-year period, and we found that again, patients with localized leukoplakia, which is the dark air blue line here, had a better probability of survival compared to the proliferative type because of the high risk of malignant transformation. And a similar pattern was also seen in patients when cancer-free survival was considered. So again, localized leukoplakia had a better probability of survival compared to the proliferative type when we followed these patients over time. More recently, we presented our data on clinical trial looking at the use of PD-1 inhibitor, in this case nivolumab, for the management of high-risk leukoplakia. Patients with proliferative leukoplakia received initial biopsy pre-treatment and were allocated to receive nivolumab for infusion, one infusion every 4 weeks, and then received subsequent biopsies and ongoing oral medicine surveillance along with head and neck oncology and intraoral photography. And we also looked at some correlatives during the trial. And my colleague represented the results at ESMO a few months ago. We included 33 patients, and the median number of nivolumab cycles delivered was 4, and the median time from the first day of nivolumab to post-treatment biopsy was about 3 months. And the cancer-free survival was 78% among this high-risk population. And the majority of patients had also a very good clinical response. As you can see here, this was a patient with a huge proliferative leukoplakia, and as in the second picture here, you can see that there was complete resolution of the lesion. This is what we consider a complete response. Some other patients had a partial response, which is still a very, very good finding. As you can see here, the patient had a mix of red and white lesions in what we call proliferative erythroleukoplakia. Typically, 90% of these patients transform into squamous cell carcinoma. In post-4 infusion, you can see here that there was some little residual disease, but definitely there was a shrinkage of the lesion, and also the erythematous component resolved completely. Another interesting approach for the management now of leukoplakia, these are unpublished data. We just submitted an abstract. We started treating some of these extensive leukoplakias with imiquimod. Imiquimod has a very non-specific mechanism of action, but it has an anti-inflammatory effect. And these patients are treated topically using a tray where possible, or a gauze to maintain the cream in the right location. The treatment consists of daily application for about 6 weeks. And as you can see here, this is the pre and the post. Patient had a leukoplakia that involved the right buccal mucosa and the gingiva, and this is a 1-year follow-up with almost complete resolution of the precancerous lesion. So pretty impressive. We also had 2 interesting cases that we published a couple of years ago. This was a patient with a history of MDS that transitioned to acute myelogenic leukemia, received allogeneic stem cell transplantation, and developed chronic graft-versus-host disease of the liver, the skin, and the eyes. And we were consulted for these white lesions of the palatal mucosa. All the biopsies showed hyperkeratosis, no dysplasia, with no signs of graft-versus-host disease. The patient was diagnosed with proliferative leukoplakia, which is the high-risk type associated with increased risk of malignant transformation. And these patients received by the oncologist ibrutinib for the management of the GVHD. And what was interesting is that also the leukoplakia had a regression and a response. We still are not completely sure why these patients respond, but it may be worthwhile exploring in the future with a trial. They use also ibrutinib for the management of some of these high-risk type leukoplakias. Last year, a year and a half ago, we looked at the benefit of having a dental specialist involved in the cancer team, specifically in the management of oral complications for patients who were diagnosed with oral cavity or oropharyngeal cancers. We looked at a large claim data set, and we found that when the oral complications from oral and oropharyngeal cancer treatment were considered, Having a dental specialist involved in the care of these patients was associated with decreased duration of the complications, but also a decreased cost for the management of these complications. So not only patients benefit from having a dental specialist or an oral medicine specialist as part of the cancer care team, but also from a public health standpoint, there's definitely a big impact, and there's value in having a specialist involved in the care of these patients. Here at Baptist, we manage also patients with benign pathology. And I mentioned the dry mouth earlier. We also manage patients with orofacial pain conditions, burning mouth syndrome, or TMJ problem. So if a patient has persistent or painful sore or any bumps or lumps that don't resolve in the mouth, we are here to help. We are here to see these patients and really accompany them during their journey. There's a variety of autoimmune vesiculous bolus disorders that we manage also together with dermatology, such as mucous membranous pemphigoid or pemphigus vulgaris. Some of these conditions typically tend to start in the mouth, and then a percentage of these also involve genital mucosa or the skin, depending on the condition considered. So mucous membranous pemphigoid tend to affect the mucosa of the patient, usually the buccal mucosa, the lips, in some cases the palatal mucosa, and they respond really well to topical treatment with steroids typically. Pemphigus vulgaris, the lesions tend to affect the gingiva, but also other areas in the mouth. These patients require not only topical treatment, but also systemic management with there are a variety of immunosuppressants without going into details, but they also respond well to rituximab, or more recently also IVIG, or a combination of the two, depending on the severity of the disease, and they luckily now go into remission in most of the cases. Lichen planus is also another condition that we can help you with. This is an immunomediated disease. Some of the cases are idiopathic, some are related to drug-induced hypersensitivity reactions. They tend to affect more women compared to men. And clinically, patients may present with reticular vacant striae, which are these white areas that you see on the buccal mucosa of these two patients. They can also present with gingival erythema, so redness, or ulcerations. And typically when patients with oral lichen planus are diagnosed with this condition, 30% of these patients eventually will develop also genital or cutaneous lesions. In terms of treatment and procedures, we can offer biopsy of oral lesions or excisions, intralesional steroid injections for some of the larger ulcerations, non-surgical sequestrectomy of the jawbone, like those examples that I showed you for osteonecrosis of the jaw, whether medication-related or osteoradionecrosis, trigger point injections for orofacial pain conditions, and we manage patients both topically and systemically from a medical standpoint. So in summary, I gave a general overview of what oral medicine is. As many of you know or don't know, this is a relatively new specialty. We are here to help you, to accompany the patients during and after treatment, or if they have any oral lesions, we are happy to answer any questions and help you. When we consider cancer patients, patients may develop both acute or chronic oral complications, some of which require to be followed for the rest of their lives, and referral to a specialist, especially for oral toxicity from cancer therapy, and diseases that affect the mucosa or the jawbone may be required in the management of these patients. So these are my contact information. I included my email, my cell phone. Feel free to contact me anytime. I'm available. And I think that we also have some time for some questions. So thanks again for having me. And thank you, everyone, for attending today.
Thank you so much, Dr. Villa, for that incredible recap. You did it in no time. That's phenomenal. And you did state it well. I mean, this is almost a brand new specialty. We are very, very fortunate to actually be able to count with your expertise, especially at Miami Cancer Institute. Oftentimes in the past, these patients will deal with their sequelas of the treatment after oncological, either radio oncology or chemotherapy. And they will be left with, topical washes here and there and nothing really to decrease the pains and suffering that the oral mucosa can bring to a patient aside from their pathological condition that they're dealing with. It's remarkable. Three of the conditions that you mentioned, the lichen planus, the leukoplakias, and pemphigus vulgaris, has always been one of those challenges for either the dermatologist who comes across them or also the internist when they see them, and it's like, oh my goodness, what do we do? Who do we refer to? They tend to refer to oral maxillary surgeons, if not a dermatologist first, so there's a lot of waste of time on that. In the Southern Cone and the Caribbean, these three conditions are still dealt with from very old ways of actually dealing with, from using silver nitrate in some cases to burn the lesions to sometimes removing them. Obviously, we have come a long way from that. But in regards to the lichen planus, can you again recapitulate and tell us how is the approach? How difficult or how easy is it now to deal with this particular condition?
Yeah, so thank you for the good question. The lichen planus is ultimately, it's an immunomediated disease, so the behavior is similar to an autoimmune disease. It's a chronic condition. In some cases, as I mentioned, is a drug hypersensitivity reaction. For example, some of the antihypertensive agents have been associated with the development of lichen planus-like lesions. Patients typically tend to respond well to topical steroid therapy. We also have other immunosuppressive agents available, such as cyclosporine as a swish and spit or tacrolimus that can be used. There is a small percentage of patients that do not respond to topical therapy and require systemic treatment. Plaquenil represents one option for these patients, but I recommend that they're seen by a specialist if if the physicians are not able to manage the topic with topical therapy, or if they're not familiar with what's available and how to prescribe these agents. The contact time for topical therapy is really what makes the trick. So when a steroid is prescribed, for example, in the form of a solution like dexamethasone, it's recommended that patients rinse for about 3 to 5 minutes. The reason why is because there's saliva in the mouth that tends to wash away everything. So the contact time is really what initially makes the trick. But there are also some side effects with the use of topical steroids, including candidiasis, for example, sometimes heartburn if the patient swallows a little bit of these steroids. So there's some considerations that we need to take into account.
Mm-hmm. And the great news is that obviously there are ways of actually dealing with that. So that is phenomenal. Karen has a question, and she is saying, is a recurrence of an aphthous ulcer cause for concern?
That's a great question. So if a sore recurs in a different spot, and typically canker sores, which is recurrent aphthostomatitis, they're cyclical. There are different types. They tend to resolve within 10 to 14 days. Canker sore, aphthous ulcer tend to be round and yellowish in color with an erythematous halo. However, it's an ulcer, and as for any ulcer, they can be also a manifestation of another condition like pemphigus, or some of these recurrent aphthous ulcers can also be an initial manifestation of a systemic disease. Crohn is one of them. So for example, if a patient also has other symptoms like diarrhea or constipations that doesn't go away and canker sores, that should be like a red flag. And then canker sores can also be a manifestation of a gluten hypersensitivity reaction, so in celiac disease, or vitamin B12 deficiencies. So again, if the sore recurs in different spot and it's round, it's probably recurrent after stomatitis, which is very common in 20% of the population as it. But if in doubt, it's good to do a referral to a specialist.
We agree. There is a myriad of conditions that actually produces an osseous lesion. So absolutely, very well said. Wilbur Edison from Sao Paulo is saying, congrats, Dr. Alessandro, for your lecture. Can you give us more information about the imiquimod? How does it act? It could be applied to varicose leukoplakia or just normal leukoplakia. Greetings from Sao Paulo, Brazil.
Yeah, good question also. So imiquimod has a profound anti-tumoral activity, and it acts at an immunological level, at different levels, and specifically it stimulates and activates the toll-like receptor 7. This is a very, though, non-specific mechanism of action. There was a case report that looked at the use of imiquimod in the treatment of proliferative leukoplakia, and these patients were the only patient that was included in the study had a very good response. I mentioned earlier that we are in the process of writing up a paper. We included 35 patients, and about 70% of these patients had a response, including some of the proliferative leukoplakia patients. Now, this is a relatively small number, and we have follow-up data for about a year. So we don't know what happens after 2-3 years. Patients may have a recurrence, and we are using this as off-label. So it will be interesting to set up a randomized control trial in the future, and we are already talking about that to really validate these preliminary findings.
That's going to be a phenomenal study if you can actually get to that level.
Yes,
we're looking forward to that.
Get in there.
Yes, I know. When you do research, it's always like a painstakingly process. You go back and forth until you get to the pinpoint section. So good luck with that. Fernanda says, do people with dental extractions or dentures represent a risk for developing any of these oral conditions?
So when we consider, that's a good question also, thank you. When we consider oral complications from cancer therapy, as I mentioned earlier, having a surgical procedure that involves the manipulation of the bone, like in extraction, can pose a risk for the development of some of the complications. So if a patient is on bone modifying agents, they may develop osteonecrosis. If a patient receives radiation to the head and neck, they may develop osteonecrosis. Poor dentition per se, and periodontal disease specifically, it's also been associated with cardiovascular disease, diabetes, and adverse related pregnancy outcomes. But there's no known correlation of having dentures and the development of, for example, an autoimmune disease that affect the mouth. If a denture, for example, is not well fitted, it may cause some traumatic lesions for patients that may present as ulcerations in the mouth, but removing the cause of trauma ultimately leads to a complete resolution of these lesions.
Yeah, similar to patients that have new braces, for instance, they'll develop these horrendous little lesions that Ambisol will take care of.
There you go, exactly.
Yeah. We don't want to make a light of a situation, but definitely oral mucosa has always been an unknown for physicians. We always rely on dentists and doctors in dentistry to actually help us understand the direction we should take with the patient. The oral cavity continues to be one of those fundamentally less paid attention to, especially in developing countries. And we hope that at some point, with prevention, we get to at least address some of these issues proactively. You did mention that some of these lesions are obviously precancerous. And I know for a fact that some of them are not necessarily related to a medication intake or post chemotherapy. So obviously, and you did say it well, as soon as you see that it's not healing, do not wait too long. Come and visit an oral specialist in order for you guys to address it. Dr. Villa, we can have you here for hours. It's always fun chatting with you, but you did a phenomenal job, and I want to thank you on behalf of our entire team for your time and for your dedication to our patients at Miami Cancer Institute. We're so proud of you, and we're looking forward to finishing those papers that you have ongoing. And on behalf of our entire team, Dr. Alessandro, thank you. And to all of you for participating and for your great questions. If you have any additional questions about today's presentation, please feel free to send them to BHIWebinars@baptisthealth.net. That is BHIWebinars@baptisthealth.net. We'll make sure to send them to Dr. Villa for his consideration and comments. And we look forward to seeing you all our next oncology lecture series, which is scheduled for Wednesday, April 12th, 2023. Thank you once again. Phenomenal start to the new year to all of you, and have a great afternoon. Thank you so much, Dr. Villa.
Thank you again for having me. Bye now.
Bye.